Hello. Thanks for joining us today. My name is Dr. Abhay Parikh. I'm a gastroenterologist at Hoag Hospital in Newport Beach, California. And I'd like to talk to you guys about colorectal cancer screening today. It's something that everyone dreads, but everyone needs. So we're going to talk about this, then we'll have some room for questions at the end. Colon cancer accounts for approximately 1 out of every 10 cancer deaths every year. So it's a very common disease, unfortunately, and it's something that is mostly preventable, and we're going to talk about that. It's the second leading cause of cancer in this country. The majority of these cancers and deaths can be prevented by increasing awareness and doing screening according to the recommended guidelines. Approximately 50,000 people die a year from colon cancer, and affects men and women fairly equally. So what is colorectal cancer? It's an uncontrolled abnormal cell growth which can start in the colon or the rectum. The rectum is the very last part of your large intestine, which is the colon. The colon is about 5-6 feet long. These cells can then grow and form a mass of tissue, which over time, from a polyp, can turn into cancer. A polyp is a growth which really shouldn't be there. Most of the polyps are usually fairly harmless. Over time, unfortunately, some of these polyps can develop cancer, and which can be problematic if it's found at a late stage. Unfortunately, we can't predict which ones are going to turn into cancer for sure, which ones are not. So the growth from normal tissue to cancer usually takes a very long time in average risk people. There's probably some genetic mutation which sets off the tissue to turn into a polyp, which can then turn into colon cancer. And usually that time frame is about 10 years. Sometimes it can be shorter in people with higher risks. But for most people with average risk, that's about the time frame. Hence the screening, which is every 10 years, which we'll talk about for average risk screening. Again, the colon is your large intestine. It's about 5-6 feet long. So the intestinal tract starts out with your esophagus, which is the food pipe, which goes into your stomach. That then goes into your small intestine, which is about 15-18 feet long, and then it goes into your large intestine, which is your colon. And then the rectum is the very last part of the colon. Then it empties into the anus. The polyps are little growths of tissue which can occur anywhere in the colon. They can be flat, raised, or they can be on a stalk, what we call pedunculated polyps. It's like a broccoli stalk. So what are the risk factors for colon cancer? Remember that having risk factors doesn't mean that you're going to get colon cancer, but unfortunately they increase the chance of you developing colorectal cancer. So we're going to talk about some risk factors. So some of the lifestyle factors which increase your risk of colorectal cancer is diet. A diet high in red meats, beef, pork, lamb, liver, processed meats. Cooking meats at high temperatures is not good. The processed meats especially are problematic. Physical inactivity is an issue. So exercise is important. Obesity is a risk factor for colon cancer. So you want to watch your weight, and again, exercise like we talked about. Tobacco is another risk factor. And smoking, for many other reasons, it should be avoided, but certainly it's a risk factor for colon cancer. Also, heavy alcohol use is a problem as far as polyps and colon cancer. So some of the other risk factors, one is age. We can't do anything about that, so age over 50. The other is a family history of colon cancer or polyps. That's another risk factor that you can't do anything about. There are certain inherited syndromes which can increase your risk of colon cancer. Having polyps yourself in the past or having colon cancer yourself in the past obviously is an increased risk for polyps and colon cancer again. And having a history of inflammatory bowel disease such as ulcerative colitis, Crohn's disease is also a risk factor for increased risk of colon cancer. And then there are some racial and ethnic backgrounds. In African Americans, the recommended age for screening is 45 years as opposed to 50, though recently you may have heard that the American Cancer Society decreased that age to 45 for everyone. Unfortunately, not all the insurance companies have followed through on this, but you know, the screening age is being pushed down, and at some point I believe that age 45 will be the screening for everyone, and it should be covered then by all insurance companies going forward. So what are some of the signs and symptoms of colon cancer? Unfortunately, early colon cancer, usually one has no symptoms. If symptoms are present, they can include such as changes in your bowel habits, feeling like you need to go have a bowel movement, bleeding. The bleeding can be red, maroon, or even darker depending on what part of the colon it's coming from. If it's coming from very low down, close to the anus, it may be red. If it's slightly higher up, it can be maroon, or it's very high up in the very top part of the large intestine. It sometimes can be black. So certainly don't ignore any sort of changes in color in your stool which suggest blood. Abdominal pain, cramping in the belly certainly is, can be a cause of concern. So if that's happening, that needs to be evaluated. Feeling weakness, feeling fatigued, that's usually a sign of anemia. If you have a cancer or a polyp, which is high-grade polyp, which is intermittently bleeding, you may not be actually seeing the bleeding, and it could be bleeding intermittently, and over a period of time you can get anemic from that and feel weakness and tired and be fatigued. Another one is unintended weight loss. That can be a problem. Certainly, if you're having any of these symptoms, we urge you to talk to your physician about any of these symptoms and seek appropriate care. So screening is very important. Colon cancer is preventable. Also, if it's an early diagnosis, even if that polyp has turned into cancer, an early diagnosis means better chance at a successful treatment. One needs to obtain regular colon cancer screenings, find any polyps or abnormal growths early and remove them. And you want to prevent colon cancer or find it in its early stage when it's certainly much more treatable. So what are the types of screenings one can seek out? So I've got a list of 4 things up here. Obviously, one's the colonoscopy. That's considered the gold standard. Then there's the stool test. Then there's a CT scan called virtual colonoscopy. So colonoscopy is a flexible lighted tube, which is, and the procedure is usually done in a surgery center. At Hoag, we have the Hoag Endoscopy Center in the 500 Superior Building and the one in Irvine. And you will have taken a laxative prep the night before. You'll come in, we'll put an IV in you. You'll be lying on your left side. Then we'll give you sedation to get you drowsy. And then we pass a tube through the bottom and go all the way to the end of the colon and watch it on a monitor. If we see any polyps, we'll remove them at that time. The procedure takes roughly 20-30 minutes to do. Budget about 2.5 hours that day. There are some risks to this procedure. The risks include, but not limited to, risk of bleeding, infection, the risk of perforation, which is an accidental hole through the intestine requiring an operation. That risk is small, less than 1 in 500 to 1,000. Other potential risks include risk of injury to other organs such as the spleen, rare risk of reacting to the sedative that we give you to get you drowsy. And as with any test, even though it's still considered the gold standard, the clean out has to be very important. The better the clean out, the less chance that your physician will miss any sort of polyps. So it's very important to do a good clean out. And what I tell patients is, look, if you're going to do it every 10 years, you know, just go with the flow and do the prep. Sedation-wise, there's 2 types of sedation offered for a colonoscopy. One is moderate sedation given by our gastroenterology nurses, and it usually consists of fentanyl and Versed. In the old days, we used to call this twilight. There's the other sedation is deeper sedation with an anesthesiologist, and that's where they usually give you a medicine called propofol. And there'll be an anesthesiologist who gives that to you. On the colonoscopy, if there's no polyps, it's every 10 years. If there are polyps, based on the number and the type of polyps that we see under the microscope, we would decide the next interval. It may be 5 years, maybe 3 years. So it all kind of depends on what is found. The other options are virtual colonoscopy, which is a CT scan of the colon. You still have to get cleaned out for that. And it's where you go to a radiology suite and they put air in your rectum and they turn you in different positions and do a virtual scan of your inside of your colon. Upside on this is there's really no risks involved with this. The downsides are if they happen to see a polyp, you got to come back and do a regular colonoscopy anyway. The other thing is that because the resolution is not as good as the regular colonoscopy, it's every 5 years on this as opposed to every 10 years. And then there's 2 stool tests. One is a stool DNA test where samples of stool are checked for blood as well as DNA changes. It's called the Cologuard test. Some of you may be familiar with that. And that's offered every 3 years. And that's usually ordered by your primary care physician. Should that test turn positive, that road also leads back to doing a colonoscopy. And the other is a stool test for FIT, where a sample of the stool is checked for blood, and that's done once a year. And that's also done by your primary care physician. And with that and the stool DNA test, there are no preparation is required. But also on the FIT test, if that is abnormal, then that road also leads back to doing a colonoscopy. So to summarize, colonoscopy, virtual colonoscopy, and the stool test. Colonoscopy is considered, again, the gold standard. Now, We've talked about a lot of things here, and I've tried to keep it at a fairly low level here, but I want you to ask me any sort of questions, and I'm happy to answer them. And so we'll see if there's any questions from our audience. Okay, so we've got one question is, how do you prepare for a colonoscopy? So it usually requires a special diet. The day before, you may be on a liquid diet or a modified diet, and it usually requires a laxative. Depending on who your doctor is, some doctors prefer certain preps over others, but they're all fairly equivalent. And just work it out with your physician as to what kind of preparation you'll have to do. But they all work. Another question is, does the colonoscopy hurt? What are the sedation options? So I talked to you about moderate sedation and deeper sedation. With the moderate sedation, it's fentanyl and Versed, which takes away the discomfort. If someone has a lot of pain, or someone's anxious, someone has a few other medical issues, cardiac issues, or lung issues, we may opt for the anesthesiologist to be there. And the advantage of the anesthesiologist is it's an extra pair of eyes, and they're experts in sedation. And the propofol sedation works well for these folks. So usually a colonoscopy should not hurt. What if my grandfather had colon cancer? So actually, the family history is usually in first-degree relatives. So if you have a first-degree relative, especially if they're younger than 60, then a colonoscopy is done about 10 years prior to that person being diagnosed with colon cancer. Say the colon cancer in a father or mother was diagnosed at 55, we would do that colonoscopy at 45. And if it was your grandfather, depending on if there's other family history, then you can talk it over with your gastroenterologist and figure out an interval. One option may be that they may do it, maybe not as every 10, but they may do it a little bit somewhere between 5 and 10. Or sometimes what you can do is you can do some of the non-invasive tests in between your colonoscopies if you're concerned, such as the stool for FIT. So how often should I get a colonoscopy? So for average risk people who don't end up having polyps, it's every 10 years. If you have 1 to 2 polyps, which are small, then it's usually 5 years if they're what we call an adenomatous polyp. If you have one large polyp, or if it's an advanced polyp like a tubulovillous adenoma, then we may do the next colonoscopy 3 years. But if that's good, then we would probably extend that interval out again. Another question is, how long does the colonoscopy last? Is it an outpatient procedure? Where is it done? These are great questions. Colonoscopy usually lasts about 20-30 minutes. Budget maybe about 2.5 hours at the surgery center that day. You'd have to check in. Obviously, the nurse will come in. You'll do a little bit of intake on you, start your IV. Then you'll come back to the procedure room for your procedure. Then we'll take you out to recovery, make sure you're doing well after the procedure, you're not having any pain, bleeding, your vital signs are stable. And on that day, you need to have someone drive you home. Unless you're one of the few brave people who opt to do a colonoscopy without sedation. And there are people who do it without sedation, but those are few and far between, but there are people who do that. Is it an outpatient procedure? It usually is an outpatient procedure. And it's sometimes we have to do it in inpatients who come in the hospital with bleeding and so forth. But screening colonoscopies, surveillance colonoscopies for people who've had polyps before, those are all outpatient procedures. And then the next question was, is it done in a surgery center or at the hospital? Most of these procedures are done at the Hoag Endoscopy Center. Some of them may have to be done at the hospital depending on the patient's medical history and medical complexity. And if someone's got a very high body mass index, say that they're very obese, and a body mass index of 50 or something like that, then someone like that we may opt to do it at the hospital instead of at the surgery center. If someone's got very advanced cardiac or lung problems, then we may opt to do that procedure at the hospital. But even those are done as an outpatient. Thank you very much. If you have any other questions, feel free to post them and we can try to reach out to you. Again, my name is Dr. Abhay Parikh. I'm a gastroenterologist here at Hoag Hospital in Newport Beach. And thanks for joining us. Appreciate it.